Hello, everybody. This week we're going to be covering Chapter 15 in OpenStax, which is psychological disorders. You're probably tired of me saying it by now, but this is also another one of those rather large chapters. It's one that covers a vast amount of information, and indeed, abnormal psychology is actually a course unto itself. And indeed, as far as clinical psychology, it's even degree majors unto itself. So, thinking of it in terms like that kind of puts a little bit more perspective when you understand that, okay, we're talking about basically a vast, vast topic that's being condensed down into one chapter. This chapter is actually also covers a topic that is very near and dear to my heart because it was actually abnormal psychology that I took as a undergrad that made me decide to pursue psychology as a degree. And it's also something as a law enforcement officer that I have used extensively throughout my career, and indeed even in my private life to large extents also. So it is something that's really near and dear to my heart, something I have a lot of passion for. So moving right into it, what are psychological disorders? Definition of a psychological disorder. Psychopathology is the study of psychological disorders, including their symptoms, etiology, which is their causes, and treatment. Psychological disorder is a condition characterized by abnormal thoughts, feelings, and behaviors. Behaviors, thoughts, and inner experiences that are atypical, dysfunctional, or dangerous are signs of psychological disorders. However, there is no single definition of psychological abnormality or normality. Just because something is atypical does not mean it is disordered. Red hair is considered unusual, but is not abnormal. Moving even further beyond that, plenty of people engage in behaviors that are not typical. They're not considered quote unquote normal. However, society sometimes rewards them for that. I mean, people like Madonna, Lady Gaga, um, a variety of performers act in ways that maybe many of us would consider to be bizarre, but they're actually kind of rewarded for it because people view them as just being so artistic and unique and fill in the blank. So definitions can change. The main overriding thought or thing to take from this is that disorders are ones that are behaviors, thoughts, and inner experiences that are dangerous or dysfunctional are kind of like key terms here to remember. So, cultural expectations. Violating cultural expectations is not enough by itself to identify a psychological disorder. Social norms vary between cultures. What is considered appropriate in one culture may be viewed differently in another. Hallucinations is a violation of cultural expectations in Western societies. However, people who report hallucinations are likely to be labeled with psychological disorder. However, in some other cultures, certain types of hallucinations are highly valued. Um, and indeed, although this says violation of cultural expectations and that they vary considerably between cultures, I would even add to that cultures change themselves over time. So when we're talking about things like the view of homosexuality in the United States, where we're at today is quite different from where we were at 20 years ago, which in turn was really drastically different from where we were at 50 or 60 years ago. So, harmful dysfunction. Wakefield in 1992 proposed a more influential concept in which he defines psychological disorders as a harmful dysfunction. So, dysfunction occurs when an internal mechanism, examples being cognition, perception, learning, break down and cannot perform its normal function. For a dysfunction to be classed as a disorder, it must also be harmful, which means that it leads to negative consequences for the individual or for others as judged by the standards of the individual's culture. Um, the other thing to kind of add to this is that by and large, it seems somewhat arbitrary to say that, cultural norms and what's abnormal versus normal changes from one culture to the next. And indeed, psychology, I think, as a whole, tries to separate itself from just cultural divisions or cultural specific abnormalities. However, it really is difficult to completely separate it from the culture that it's a part of, because we are a product of our culture. We live in our culture. So we have to deal with those cultural attitudes and those cultural exchanges. So it really is impossible to completely separate ourselves from those. The American Psychological Association definition of a psychological disorder is: a psychological disorder is a condition that consists of the following: significant disturbances in thoughts, feelings, and behaviors which are outside of cultural norms. The disturbances reflect some kind of biological, psychological, or developmental dysfunction. The disturbances lead to significant distress or disability in one's life, such as a difficulty performing appropriate and expected roles. Despite the many existing definitions, there is no universal agreement on where the boundary between disordered and not disordered is. Diagnosing and classifying psychological disorders. So, the Diagnostic and Statistical Manual of Mental Disorders, which is the DSM, diagnosis is the appropriately identifying and labeling a set of defined symptoms, requires classification systems that organize psychological disorders systematically. In the United States, we use the DSM. It is published by the American Psychiatric Association. It was first published in 1952 and has since undergone numerous revisions. The first two editions listed homosexuality as a disorder, but was removed in 1973. DSM-5 is a classification system used by most mental health professionals in the United States. It categorizes and describes each disorder. So there are diagnostic features, overview of the disorder, diagnostic criteria, the prevalence, and risk factors. It also provides information about comorbidity, the co-occurrence of two disorders. So, prevalence rates. The graph shows the breakdown of psychological disorders, comparing the percentage of prevalence among adult males and adult females in the United States. The DSM-4 has since been supplanted by the DSM-5. Most categories remain the same. However, alcohol abuse now falls under a broader alcohol use disorder category. So you see here with different percentages: major depressive disorder. Females are more likely to have major depressive disorder than males. However, both rates are extremely high as compared to other disorders. Alcohol abuse, males are far higher than females. Specific phobias, women are higher than men. Social anxiety disorder is pretty close between the two genders. Drug abuse is about twice as likely to be men than women. Post-traumatic stress disorder, most people would be very surprised to find that women have higher rates of PTSD than do men. And the reason for that is most people view PTSD as being a result of war and military, so they would believe that men would be at a higher prevalence. However, one of the most frequent causes of PTSD is victimization of sexual violence, sexual abuse, molestation, rape, things like that. So women are far likelier to be victims of that than are men. Generalized anxiety disorder, which is overall anxiety. The two are pretty close. Women are a little bit higher than men. Panic disorder, women are usually higher than men. Obsessive compulsive disorder, rates are pretty close. However, it's usually women over men. And dysthymia was mostly women over men also. So obsessive compulsive disorder and major depressive disorder frequently occur in the same person. That is known as comorbidity. This is when you have two disorders that frequently occur hand in hand with one another. The International Classification of Diseases, ICD. So the ICD is published by the World Health Organization, or WHO. Classification and criteria for specific disorders are similar to the DSM, but some differences do exist. It's used to examine general health of populations and monitor prevalence of diseases health problems internationally. Worldwide, the ICD is more frequently used for clinical diagnosis, whereas the DSM is more valued for research. DSM includes more explicit disorder criteria as well as extensive explanatory text. DSM is the classification system used among U.S. mental health professionals. So the reason why the DSM is also used more extensively for research is that it's just been around longer than the ICD. However, the DSM clearly is designed more for the United States. It's more specific to cultures within the United States. It's not really meant to be an international standard. So that's why we have these two overall standards. We need to have one that compares, rates of, say, depression in the United States versus Russia versus Africa versus Australia versus, all these different countries to see maybe cultural trends that work or don't work or that help influence depression or that prevent it. But as far as the DSM, that's used because it is more specific to the United States, to our culture, our society, our social norms, things like that. Perspectives on psychological disorders. So the supernatural perspectives. For centuries, psychological disorders were viewed from a supernatural perspective, which is psychological disorders attributed to a force beyond scientific understanding. So practitioners of black magic, sorcery, witchcraft, possessions, need for exorcisms, things along those lines. Treatments include torture, beatings, and exorcism. In the extraction of the Stone of Madness, a 15th century painting by Hieronymus Bosch, a practitioner is using a tool to extract an object, the supposed Stone of Madness, from the head of an afflicted person. Um, a lot of the overriding concepts, besides the fact that somebody was the victim of witchcraft or demon possession or what have you, was also that basically people got what they deserved. So they probably, are evil people or whatever, and they kind of got what they deserved. They got possessed by the devil. Um, Dancing mania. It was epidemic in Western Europe from the 11th century to the 17th century, in which groups of people would suddenly begin to dance with wild abandon. Some would dance for days or weeks, screaming of terrible visions. Although the cause is unknown, the behavior was attributed by many people to being supernatural forces. And indeed, there's one incident, and I can't remember what they call the disorder, but uh, it's a part of southern Italy where they have tarantulas. Well, the tarantulas really aren't dangerous, but it's the belief there that a bite of the tarantula leads to a person dancing. It leads to a manic episode in which the person could dance for days on end. And indeed, they kind of labeled this as a disorder. And there are people that have done this, that have, reported dancing for days on end because they got bit by a tarantula. And other cultures across the world have similar incidences of something similar to that. Biological perspectives. So this view is that psychological disorders are linked to biological phenomena. So genetic factors, chemical imbalances, and brain abnormalities. It is supported by evidence that most psychological disorders have a genetic component. A person's risk of developing schizophrenia increases if a relative has schizophrenia. The closer the genetic relationship, the higher the risk. So you're talking about identical twins, 100% of the genes are shared. The percent risk of developing schizophrenia is nearly 50%. Siblings, where you have about half of the genes being shared, you're talking about siblings, you're about 10 to 15%, somewhere around there. Fraternal twins, it's a little bit higher, it's almost 20%. So it is very close for schizophrenia. And schizophrenia is one of the ones that is very genetically linked. The diathesis stress model. Psychosocial perspective emphasizes the importance of learning, stress, faulty and self-destructive or self-defeating thinking patterns, and environmental factors. It views the cause of psychological disorders as a combination of biological and psychosocial factors. So the diathesis stress model holds that or it integrates biological and psychosocial factors to predict the likelihood of a disorder. So the diathesis plus stress leads to the development of disorder. People with an underlying predisposition for a disorder or diathesis are more likely than others to develop a disorder when faced with adverse environmental or psychological events. A diathesis can be a biological or psychological vulnerability. Um, just kind of going back real quick to the diathesis stress before we get into anxiety disorders. That is the general overriding consensus with most, pretty much all psychological disorders now, is that people have a predisposition, whether that is completely genetic or if it's just through the way you're raised and the way your upbringing was and events that happened in your childhood. We're predisposed to certain things. What then happens is there's a life event or several life events or you know uh, just life occurring that prevents us or permits us to develop that disorder. So say you're raised as a child in a very abusive relation or abusive family environment. Your parents are very absent. You didn't get a lot of support, and you just kind of developed a more negative outlook on the world as a result of that. Then, as an adult, maybe the first time you decided that maybe you could be loved and that you had somebody who cared about you, and you entered a relationship with them, a romantic relationship, and they ended up being a bad person or just wasn't a good relationship for you. It ended up, where they cheated on you or were abusive or something along those lines. Would that person then maybe become a little bit more predisposed to developing social anxiety or depression or something like that? Yeah, maybe, versus somebody who was raised with that support and that love or what have you, and then, maybe experienced the same kind of bad relationship, but was able to shake it off because they had the support group present or they had the psychological skills developed through childhood to buffer them against that. So that's kind of how that diathesis stress model works. So then moving into anxiety disorders. And this is where the part of the chapter we're going to break up all the disorders into main groups and then talk about them. So anxiety disorders, what we're talking about is fear versus anxiety. So fear is an instantaneous reaction to an imminent threat. Anxiety is apprehension, avoidance, and cautiousness regarding a potential threat, danger, or other negative content. Um, Anxiety motivates us to take action and avoid certain things. Level and duration of anxiety usually matches the magnitude of the potential threat. However, some people experience anxiety that is excessive, persistent, and out of proportion with the actual threat. Anxiety disorders are characterized by excessive and persistent fear and anxiety, and by related disturbances in behavior. It generally affects approximately 25 to 30% of the U.S. population during their lifetime. It's more common in women than it is in men, and is the most frequently occurring class of mental disorders. A social phobia or specific phobia involves excessive, distressing, and persistent fear or anxiety about a specific object or situation. People may realize their fear and anxiety is irrational, but may still go to great lengths to avoid the stimulus. It affects about 12.5% of the U.S. population at some point in their lifetime. Common specific phobias include acrophobia, which is fear of heights, aerophobia, fear of flying, arachnophobia, fear of spiders, claustrophobia, enclosed spaces. Um, One particularly debilitating form of specific phobia is agoraphobia, which is listed as a separate anxiety disorder. It's characterized by intense fear, anxiety, and avoidance of situations in which it might be difficult to escape or receive help if one experiences a panic attack. These situations include public transportation, crowds, being outside the home alone. Generally speaking, people who are agoraphobic are pretty much shut-ins. They're locked in their house. They do not go out. They pretty much depend entirely on people bringing stuff to them to live. They pretty much are just entirely, confined to their houses. Acquisitions of phobia through learning. Rockman in 1977 developed three major learning pathways. So we have classical conditioning, um, which some of these terms these shouldn't be shocking in the least bit. So in his view, classical conditioning, the example being a child is bitten by a dog, leads to dogs become associated with biting, which leads to child experiences fear around dogs. So the conditioned fears develop more readily to fear relevant stimuli, images of snakes and spiders, than to fear irrelevant stimuli, images of wildflowers. Um, so that's one way. That's one major pathway. So if you're a kid, you get bit by a snake, you're probably going to fear snakes. You're a kid, you get bit by a dog, you're probably going to fear dogs. Two is vicarious learning. So a child observes a cousin react with fear around spiders. Leads to that child later expresses the same fears, even though spiders have never presented any danger to him. And part of that, a lot of that, is the social learning. So if the child just relates that fear to that object, there's probably a reason, right? That's the reason why we have social learning is a part of survival. Whether it makes sense or not, we don't need to learn not to touch a hot pan by touching a hot pan. If somebody says don't touch a hot pan, or you can see smoke rising off it or something else, these are things that we learn vicariously that we don't have to, feel for ourselves. The third major learning pathway is verbal transmission of information. So a child is continuously told that snakes are dangerous. It's going to lead to a child starting to fear snakes. One of the things I think is really unfortunate is you hear parents say that don't talk to the police. The police are awful. The police are mean. Or, police are going to lock you up or something along those lines. Of course, then it's going to lead that child to have a bad idea of police. And when it comes time for the child to maybe trust the police to help them with something, they're not going to go to them because they don't trust them. So that's another example there. And indeed, I would say the verbal transmission of information, not just for these specific phobias, but just as an overall, is how things like prejudice, hate, biases, things like that are spread to our children. So why are certain types of phobias more common than others? One theory argues that because our ancestors associated certain stimuli with danger, so snakes, spiders, heights, we are evolutionarily disposed to associate those stimuli with fear. Social anxiety disorders is another disorder outside of the specific anxieties and agoraphobia. So, social anxiety disorder, sometimes labeled SAD, is characterized by extreme and persistent fear or anxiety and avoidance of social situations, in which the person could potentially be evaluated negatively by others, leading to serious impairments in life. It's associated with lower educational attainment, lower earning, poor work performance, and unemployment. This does not mean that the social anxiety disorder, just as a side note, um, that these people are less educated or are not intelligent or not capable of good work. It's that the disorder just impairs their functioning that much that it makes it difficult for them to do those things. Safety behaviors, mental or behavioral acts that reduce anxiety in social situations by reducing the chance of negative social outcomes. So, an example would be avoiding eye contact or rehearsing sentences before speaking. Prevalence, it's about 12% of Americans during their lifetime. And comorbidity, it has high rates of comorbidity with alcohol use disorder. Individuals may self-medicate in order to reduce the anxiety in social situations. And this kind of makes sense because there's a reward aspect, right? A lot of people, when they drink, especially when they drink to excess, kind of acts as a social lubricant. You open up a little bit more. And to somebody who has this crippling social anxiety, they may look at alcohol as being like this great thing that helps them actually talk to people. So risk factors, fears of social situations possibly develop through conditioning. 92% of a sample of adults with social anxiety disorder reported a history of severe teasing in childhood. Behavioral inhibition, a consistent tendency to show fear and restraint when presented with unfamiliar people or situations. This behavioral inhibition tends to be more of a personality trait. Um, so the diathesis stress model for social anxiety disorder would hold that basically people have more of this predisposition to a certain personality trait, and then they kind of get feedback through childhood by getting teased or whatever that reinforces this inhibition, and then kind of leads to the spiral of fearing social situations. Panic disorder. Panic disorder is a recurrent and unexpected panic attacks, along with at least 1 month of persistent concern about additional panic attacks, worry over the consequences of the attacks, or self-defeating changes in behavior related to the attacks. Comorbidity is with anxiety disorders or major depressive disorder. Panic attack is a period of extreme fear or discomfort that develops abruptly and reaches a peak within 10 minutes. It can be expected in response to an external trigger or unexpected. Panic attacks alone are not a disorder. Some of the physical manifestations of a panic attack are shown. People may also experience sweating, trembling, feelings of faintness, or a fear of losing control, among other symptoms. Bear in mind, and this is something a lot of people have misconceptions of what a panic attack is, and where they just think that it's in somebody's mind and they can just stop doing it. Um, there's a difference between being anxious or having a feeling of panic and having a panic attack. A full-on panic attack is extremely troubling to somebody that's going through it. And to have somebody be less than supportive and just basically say snap out of it is probably just going to cause them more a panic and be self-defeating to them. People with panic attacks have had symptoms that mirror heart attacks, and indeed even could be worse than the symptoms of a heart attack. Um, but as it mentions there, the panic attacks alone are not a disorder. But if you have this persistent feeling of having a panic attack and then discomfort and feeling concerned about it afterwards, then that's what leads to the actual disorder. Um, they believe panic disorder is about 43% heritability. The neurobiological theories, locus coeruleus in the brainstem is possibly involved. Major source of norepinephrine, which is the neurotransmitter that triggers fight or flight response. Activation is associated with anxiety and fear and produces panic-like symptoms in non-human primates. Conditioning theories, panic attacks are classical conditioning responses to subtle body sensations resembling those normally occurring when one is anxious or frightened. And then we have cognitive theories, which hold that individuals with panic disorder are prone to interpret ordinary body sensations catastrophically, setting the stage for panic attacks. In some patients, reducing catastrophic cognitions about sensations has proven to be as effective as medication in reducing panic attacks. So we have a couple different theories here. Um, the neurobiologic basically would hold that the neurotransmitter that you have overproduction of the neurotransmitter, or that the receptors for them are over sensitive, so they take in a lot of that neurotransmitter, so it predisposes somebody to being more inclined to have these fight or flight responses, be more panicked, overall have more a higher state of arousal as their baseline. Um, and then cognition and conditioning theories kind of reinforce this biological component and serve to make the disorder more pronounced. Generalized anxiety disorder, GAD, is a relatively continuous state of excessive, uncontrollable, and pointless worry and apprehension. Diagnostic criteria include the diffuse worrying and apprehension is not part of another disorder. Symptoms occur more days than not for at least 6 months. Symptoms are accompanied by any three of the following symptoms: restlessness, difficulty concentrating, being easily fatigued, muscle tension, irritability, and sleep difficulties. Prevalence, it affects about 5.7% of the U.S. population during their lifetime. Females are 2 times as likely as males to experience the disorder. And indeed, I mean, all the anxiety disorders as a whole are more prevalent with females than with males. Um, it is comorbid with mood disorders and other anxiety disorders. So causes. Cognitive theories of the cause of generalized anxiety disorder is that worry represents a mental strategy to avoid more powerful negative emotions, perhaps stemming from earlier unpleasant or traumatic experiences. So worrying acts as a distraction from remembering painful childhood experiences. Longitudinal studies have found that childhood maltreatment was strongly related to development of the disorder during adulthood. Obsessive compulsive and related disorders. So, obviously, kind of the flagship disorder for this branch of disorders is obsessive compulsive disorder, or OCD. It involves thoughts and urges that are intrusive and unwanted, obsessions, and or the need to engage in repetitive behaviors or mental acts, which is the compulsions. Obsessions are persistent, unintentional, and unwanted thoughts and urges that are highly intrusive, unpleasant, and distressing. So, common obsessions include concerns about germs and contamination, doubts, order and symmetry, aggressive or lustful urges. Compulsions, on the other hand, are repetitive and ritualistic acts, typically carried out primarily as a means to minimize the distress that obsessions trigger or to reduce the likelihood of a feared event. They're not performed out of pleasure. The person usually knows these obsessions and compulsions are irrational, but suppressing them is extremely difficult. It's This disorder is generally experienced by approximately 2.3% of the U.S. population in their lifetime. And I think OCD is one of those disorders that is used a lot for plot devices in movies. I'm trying to think. Monk was a TV series that involved a detective that was OCD. Um, there's almost a tongue-in-cheek kind of comical aspect to this disorder, but those who have it can be really debilitated by it. It's funny to think of somebody having to check the stove, 5 or 6 times before they leave for work. But when you talk about somebody doing that over and over and over again to the point that they're not showing up for work on time, or that it takes them an hour just to leave the house because they're constantly leaving the house and then going back into the house to check to see if the stove's off, over the course of an hour, that can get really problematic for the person. It can really interfere with them living a happy, normal life. Repetitive hand washing and checking are common compulsions among those with obsessive compulsive disorder. Other common compulsions include cleaning, ordering, and counting. One of the things that's kind of key, no pun intended, I guess, with the picture here, um, about some of these repetitive rituals that happen with OCD is that in and of themselves, it doesn't seem negative, right? So washing your hands is good, prevents bacteria, prevents infections, can help you keep you from getting sick. So keep washing your hands, and if that's a good act, then doing it 5, 6, 7, 8, 9, 10 times is probably just as good, if not better, right? Making sure your house is locked is a good thing, but when you do it for over an hour and you're not showing up for work because of it, is it really a good thing anymore? Moving on to the next disorder is body dysmorphic disorder. It involves a preoccupation with a perceived flaw in the individual's physical appearance that is either non existent or barely noticeable to other people. Causes a person to think they are unattractive or deformed. Typically involves skin, face, or hair, but can focus on any body area. Causes person to engage in repetitive and ritualistic behavioral and mental acts. So, constantly looking in the mirror, trying to hide the offending body part, comparison with others, um, and then becoming fixated with ideas of cosmetic surgery. Prevalence is about 2.4% of the adults in the United States, with slightly higher rates in women than in men. However, they're about equal. And that's shocking to most people, too, because I think those who know the disorder, or at least know what it is, would tend to think or be biased in thinking that women were more prevalent than men. Hoarding disorder involves great difficulty in discarding possessions, regardless of how valueless or useless they are, usually resulting in an accumulation of items that clutter living or working areas. Why are they unable to let go of the items? They think the items may be useful at a later time or have sentimental attachments to them. Excessive clutter prevents the individual using necessary living space, such as the kitchen or bed. It's diagnosed as long as the hoarding is not a symptom of another disorder. And a good example of this and how it can be and how a lot of these disorders kind of bleed into one another is somebody who's depressed, who has major depression, maybe wouldn't feel like cleaning up their house because they just don't care anymore. They kind of gave up hope. So somebody who has a house that looks like this, but it's because of a major depressive episode, wouldn't be considered to have a hoarding disorder. They'd be considered to have major depression. So this is kind of once everything else is ruled out, then they'd be diagnosed as having a hoarding disorder. This is going back to OCD causes. So genetics, 5 times more frequent in first-degree relatives of people with OCD. Identical twins, more common than with fraternal twins. Um, Conditioning theories, symptoms of OCD are learned responses resulting from both classical and operant conditioning. And don't be confused, this is OCD, but this is also all obsessive compulsive disorders. Um, once association has been acquired, encounters with the NS trigger, which is the neutral stimulus, trigger anxiety and obsessive thoughts. Anxiety and obsessive thoughts continue until a strategy is identified to relieve it. Relief may be ritualistic behavior or mental activity that reduces anxiety. Compulsive acts become negatively reinforced. Brain anatomy, OCD circuit. Several interconnected regions that influence perceived emotional value of stimuli and selection of behavior and behavioral and cognitive responses. Um, Abnormalities in these areas may produce symptoms of OCD. The orbitofrontal cortex is involved in learning and decision making. It becomes hyperactive in people with OCD when provoked with tasks such as looking at photos of a toilet or a picture hanging crookedly on a wall. Post-traumatic stress disorder, and this is a disorder that is very near and dear to my heart. I've known several people that have had this disorder, so it's something that I actually care quite a bit about, and I've done a lot of volunteer work working with this population. So, diagnostic criteria. Individual was exposed to, witnessed, or experienced the details of a traumatic experience. So, actual or threatened death, serious injury, or sexual violence. PTSD was first recognized in soldiers who had engaged in combat. Symptoms occur for at least 1 month. Symptoms are intrusive and distressing memories of the event. Flashbacks, which are states during which individual relives the event and behaves as if it were occurring at that moment. Avoidance of stimuli connected to the event. Persistently negative emotional states, feelings of detachment from others, irritability, proneness towards outbursts, and exaggerated startled response. It's experienced by about 7% of the U.S. population, and as we mentioned previously, most people are surprised to learn that females are more prevalent. It's more prevalent with females than it is with men. Risk factors. So, number one risk factor is a traumatic experience. Those involving harm by others carry greater risk than those that do not. Lack of immediate social support. Social support is the comfort, advice, and assistance from relatives, friends, and neighbors. It can reduce the risk of developing PTSD dramatically. And indeed, now the military has recognized this, and has systems in place. I think most occupations that deal with with higher prevalence rates of PTSD, such as um, emergency services, first responders, law enforcement, military, have implemented ways of dealing with those traumatic experiences and helping their employees get through them. Um, Subsequent life stress, females again are more prone to it than men. Lower socioeconomic status, lower intelligence, personal history of mental disorders, history of childhood adversity, family history of mental disorders, personality characteristics such as neuroticism and somatization, which is a tendency to experience physical symptoms when one encounters stress, and possession of one or two short versions of a gene that regulates serotonin. So even in this case, we're talking about a somewhat genetic component. Learning and the development of PTSD. So, conditioning theories is that the traumatic event is an unconditioned stimulus, leads to extreme fear and anxiety, which is an unconditioned response. So, we didn't have to learn these, right? We didn't have to learn what a traumatic incident was. We didn't have to learn how to have extreme fear and anxiety from it. Cognitive, emotional, and psychological and environmental cues associated with the traumatic event become conditioned stimuli. So the traumatic reminders are the conditioned stimuli, which leads to extreme fear and anxiety, which is the conditioned response. I think this is a way oversimplified explanation of PTSD. However, it's one that kind of does make sense to a lot of people and is very easy to understand. Cognitive theories hold that there are two key processes in development and maintenance of PTSD. So, disturbances in memory for the event. Poorly encoded memories of trauma can become fragmented, disorganized, and lacking in detail. Individuals cannot remember the event in a way that gives meaning and context. They may become haunted by these fragments and voluntarily triggered by stimuli associated with the event. The second key process is the negative appraisals of the trauma and its aftermath, such as I deserve to be raped because I am stupid. It may lead to dysfunctional behavioral patterns that maintain symptoms and prevent changes in the problematic appraisals. Um, Before we get into mood disorders, just to kind of recap, one of the other things, and this is something that um, people have kind of picked up on, that in terms of the military with PTSD, one thing that's interesting is that um, one theory holds that basically PTSD serves as a survival mechanism. So, generally speaking, soldiers in that setting who have PTSD and are experiencing PTSD symptoms, those symptoms are actually really beneficial to them in those environments. Because, I mean, you're talking about symptoms such as hypervigilance. Well, it's probably good in a war zone to be extremely vigilant, to be extremely aware of your surroundings. So the problem doesn't present itself in those situations. The problem presents itself when the person is removed from that abnormal area and brought back home. And indeed, one of the ways that people think of viewing PTSD is that it's a normal response to an abnormal situation. So it is perfectly normal to feel fear when you're threatened, or to be hyper vigilant when you're in situations where you think that danger presents itself, um, around every corner. But when we start associating those responses to walking down the street or going out of your house to get the mail, or a fireworks display on the 4th of July, it becomes really traumatic and really problematic for us. So that's kind of the overall thing with PTSD. Mood disorders, and these are a multitude of them. Mood disorders are characterized by massive disruptions in mood and emotions that can cause a distorted outlook on life and impair ability to function. Depressive disorders involve depression, which is the intense and persistent sadness, uh, are the main feature. Bipolar and related disorders involve mania, which is extreme elation and agitation, as the main feature. Manic episode is a distinct period of abnormally and persistently elevated, expansive, or irritable mood and abnormally and persistently increased activity or energy lasting at least 1 week. Major depressive disorder. So, diagnostic criteria: a depressed mood most of the day, nearly every day. Most or loss of interest and pleasure in usual activities. At least 5 symptoms for at least a 2 week period. Symptoms can cause significant distress or impair normal functioning and are not caused by substances or a medical condition. Major depressive disorder is episodic, which means that symptoms are usually present at their full magnitude for a certain period of time and then gradually diminish. So, some of the symptoms, and again, you need to have at least 5 being present for a 2 week period, would be weight loss or weight gain, increased or decreased appetite, difficulty falling asleep or too much sleep, psychomotor agitation or psychomotor retardation, fatigue or loss of energy, feelings of worthlessness or guilt, difficulty concentrating, indecisiveness, and then suicidal ideation, which is thoughts of death, thinking about planning suicide, suicide attempts. About 6.6% of the U.S. population each year and about 17% of the U.S. population in their lifetime will be affected by major depressive disorder. It is more common among women than it is among men. It is also comorbid with anxiety disorders and substance abuse disorders. And the substance abuse part is because if you're really feeling down and depressed and alcohol makes you feel better, or marijuana or heroin or cocaine, then you're going to self medicate and you're going to start using those things as a way of dealing with your depression. Risk factors: unemployment, low income, living in urban areas, and then being separated, divorced, or widowed. Subtypes of depression. Seasonal pattern applies to situations in which a person experiences the symptoms of major depressive disorder only during a particular time of the year. Uh, Generally speaking, that's for far northern latitudes where you have much less daylight during the winter months. Peripartum onset, which is postpartum depression, is major depression during pregnancy or in the 4 weeks following the birth. And indeed, there's been many high profile cases of new mothers having postpartum depression and killing their children, killing themselves, etc. Persistent depressive disorder or dysthymia is depressed moods most of the day, nearly every day for at least 2 years, as well as at least 2 of the other symptoms of major depression. Chronically sad but do not meet all the criteria for major depression. So this is more of a, I hate to say lower level, but it's a less intense version of major depression. But just because it's less intense doesn't mean it can't be problematic. You're talking about 2 years. Imagine feeling depressed for 2 years, even if it's not this massive major depression. Having a depressed mood for 2 years is still very traumatic and problematic for a person in their life. Bipolar disorder. It involves mood states that fluctuate between depression and mania. Symptoms of mania are excessively talkative, excessively irritable, exhibit a flight of ideas, so they talk loudly and rapidly, abruptly, switching from one topic to another, and generally not really making any sense in what they're saying. They're easily distracted. They exhibit grandiosity, inflated but unjustified self esteem and self confidence. They show little need for sleep, and they take on several tasks at once. They also engage in reckless behaviors. This is especially more advanced into the manic episode. It'll become more reckless. Prevalence onset is typically before the age of 25. It affects 1 out of 100 people in the United States in their lifetime. 36% of these individuals do attempt suicide at some point. It is also comorbid with anxiety disorder and substance abuse disorder. Again, substance abuse disorder, because a lot of these people are very disturbed by their disorder. So if they start associating alcohol or drugs or something else as being a way of dealing with it, then they start self-medicating themselves. Biological basis of mood disorders, genetics, major depressive disorder, relatives have double the risk of developing the disorder. Identical twins, there's about a 50% concordance rate. For fraternal twins, it goes down to about 38. So it's a pretty high rate. Bipolar disorder, however, is even further. So relatives have over 9 times the risk. Identical twins are 67% concordance rate. Fraternal twins are 16% concordance rate. Um, if that seems a little bizarre to you, that the fraternal twins are lower, whereas the identical twins are higher compared to major depressive disorder, I don't really know what the explanation is for that. I do know bipolar disorder, generally speaking, is more linked to genetics. Hormones. Elevated levels of cortisol, which is the stress hormone, are found in depression. So is it the cause or is it the consequence of the depression? That's really the question, right? Nature versus nurture again. So, a risk factor for future depression is having elevated levels of cortisol. Cortisol activates the amygdala and deactivates the prefrontal cortex. So, disturbances connected to depression. And again, if you think of the amygdala as being that kind of gut, visceral, raw emotions, and the prefrontal cortex as being higher level thinking, you can see where somebody who's shutting down that higher level thinking and focusing more on the amygdala is going to be more inclined to have these stronger emotions. Neurotransmitters. Mood disorders often involve imbalances in neurotransmitters, particularly serotonin and norepinephrine. These neurotransmitters are involved in body functions that are disrupted in mood disorders. Many medications designed to treat mood disorders work by altering neurotransmitter activity in the neural synapse. Medications for depression usually increase serotonin and norepinephrine activity. Medication for bipolar disorder include lithium, which blocks norepinephrine activity at the synapse. Brain anatomy, depression, the amygdala. It's important in assessing the emotional significance of stimuli and experiencing emotions. Depressed individuals react to negative emotional stimuli, such as sad faces, with greater amygdala activation than do non-depressed individuals. They're also more prone to react emotionally to negative stimuli. The prefrontal cortex is important in regulating and controlling emotions. Decreased activation in depressed individuals, which may inhibit its ability to override negative emotions. Greater difficulty controlling emotional reactions. Hmm. So, diathesis stress model and major depressive disorders. Stressful life events often precede the onset of depressive episodes. However, not everyone who experiences stressful life events develop depression, suggesting predispositions or vulnerability factors could be involved. So, genetic vulnerability. Alteration in the 5-HTT-LPR gene, which regulates serotonin. One or two short alleles plus stressful life event leads to an increasingly likely to experience a depressive episode. So, a study on gene-environment interactions in people experiencing chronic depression in adulthood suggests a much higher incidence in individuals with a short version of the gene in combination with childhood maltreatment. Cognitive theories of depression. So, the cognitive theories suggest that depression is triggered by negative thoughts, interpretations, self-evaluations, and expectations. In this example, the diathesis stress model would be a cognitive vulnerability plus stressful life event leads to depression. Aaron Beck in the 1960s theorized that depression-prone people possess mental predispositions to think about most things in a negative way, which is known as depressive schemas. So these depressive schemas contain themes of loss, failure, rejection, worthlessness, and inadequacy. They may develop in childhood in response to adverse experiences, such as abuse or neglect. They're dormant until activated by stressful or negative life events. Prompt dysfunctional and pessimistic thoughts about the self, world, and the future. They're maintained by cognitive biases, which lead us to focus on negative aspects of experiences, interpret things negatively, and block positive memories. This is supported by research since then, and at least it led to the development of cognitive therapies. So basically, and I think we all kind of know these people that are just sort of negative and just, downers. That's just kind of like the way they are. It's their personality trait. So that doesn't mean they're depressed. However, when you have somebody who has this kind of aversion to it and they're experiencing a lot of like negative things in their life, um, it sort of reinforces in their mind this negative outlook of the world. So, somebody who's kind of naturally a little bit pessimistic and maybe, they came from an abusive environment that really led to them having a negative outlook on the world, now they're adults and they're kind of making the most out of their life, and then something really bad and horrible happens to them, or that's stressful to them. Maybe even something that isn't necessarily negative, like, leaving their family and going to college, where they feel kind of threatened, they feel a little worried, maybe they're not sure if they're going to fit in or not. That's a stressful situation, even if it's a positive thing. Um, so then something like that, they're going to be more aware of how they don't fit in, how they don't belong, how, maybe they're too fat or they're not as smart as other students or whatever. And it leads to this cognitive problem of basically making themselves feel worse about themselves. The hopelessness theory. Specific negative thinking style leads to sense of hopelessness, which then leads to depression. So negative thinking refers to a tendency to perceive negative life events as having stable and global causes. So stable would be like it's never going to change, and global being it's going to affect my whole life. Creates the view that life event will have negative implications for the person's future and self-worth, increasing likelihood of hopelessness. Hopelessness is the expectation that unpleasant outcomes will occur or desired outcomes will not occur, and there is nothing one can do to prevent such outcomes, seen as primary cause of depression. um, Rumination is the repetitive and passive focus on the fact that one is depressed and dwelling on depressed symptoms rather than distracting oneself from the symptoms or attempting to address them in an active problem-solving manner. It's described to explain higher rates of depression in women who are more likely to ruminate than men. So the cognitive idea of rumination is distress mood leads to rumination, which then leads to increased risk and duration of the mood. Suicide. 90% of those who complete suicides have a diagnosis of at least one mental health disorder, most frequently a mood disorder. Is the 10th leading cause of death for all ages in 2010. An average of 105 suicides are carried out in this country every day. 4 times higher among males. 79% of all suicides are males than are females. Males are most commonly use a firearm. Females most commonly use poison, and that also includes overdose deaths. Although males are pretty common with overdose deaths also. Risk factors. Substance abuse problems, 10 times greater in individuals with alcohol dependence. Suicide is 10 times greater. Previous suicide attempt, access to lethal means in which to act, such as a firearm in the home. Precursors, so withdrawal from social situations, feeling like a burden, engaging in reckless and risk-taking behavior, also giving away items, uh, possessions to other people is another big red flag. Sense of entrapment, so feeling unable to escape feelings or external circumstances. Cyberbullying has been added as being a risk factor for suicide. The recent suicide of a family member. And indeed, it doesn't list it on here, but this is especially common in high schools and other schools, is a well publicized suicide usually leads to more suicides. And also a suicide in the school where it's somebody who is known to students will lead to additional suicides or can lead to additional suicides. Um, Also, a serotonin dysfunction, just like with all mood disorders, has been linked to suicide, higher risk of suicide. Schizophrenia. So, schizophrenia symptoms include hallucinations, which are perceptual experiences that occur in the absence of external stimuli. So, auditory hallucinations are the most common. There's also visual stimuli. There's also, which is very not as common at all, as the motor hallucinations. So, feeling things on you that aren't there. Frequently, with people with schizophrenia, this can be stuff like feeling worms under your skin or feeling that maybe you're being operated by somebody inside your brain. Delusions are beliefs that are contrary to reality. So, paranoid delusions are the belief that other people or agencies are plotting to harm them. Grandiose delusions are the belief that one holds special power, unique knowledge, or is extremely important. Somatic delusions are beliefs that something highly abnormal is happening to one's body. Thought withdrawal or insertion, which with those, they're very common where you see people that are just staring, um, almost completely detached from anybody else. They may just be staring at a blank wall for hours on end. Disorganized thinking involves disjointed and incoherent thought processes, and then disorganized or abnormal motor behavior, unusual behaviors or movements. Catatonic behaviors are decreased reactivity to the environment. So this goes back to thought withdrawal or thought insertion. So people who are catatonic are just going to stare at things. They may shut down. They may even freeze their bodies and not move. Those are people that are referred to as being catatonic. Negative symptoms of depression or of schizophrenia rather are decreases and absences in certain behaviors, emotions, and drives. So if you think of all these symptoms that we just talked about as being positive symptoms, these are negative symptoms. Don't confuse the fact that we're talking about positive and negative, so don't think it's good and bad. These are all symptoms of the disorder, so they're all bad. But what we're talking about with positive symptoms is that it's something that's actually stimuli is being experienced. Whereas negative means that there's something that should be present that isn't present. Um, so there are decreases or absences in certain behaviors, emotions, or drives. So we have avolition, which is a lack of motivation to engage in self-initiated and meaningful activities, such as showering. Um, Alogia, which is reduced speech output. Asociality, which is social withdrawal. And then anhedonia, which is the ability to experience pleasure. Prevalence is about 1% of the population in their lifetime. Schizophrenia is by no means a common disorder. However, it's also really not rare either. Um, it's something that is, you know, in every community. It's in all parts of the country. It's something that is universal. Every culture has their version of schizophrenia. Um, it is highly genetically linked. So the risk is 6 times greater if one parent has schizophrenia. Um, and it's not 6 times greater if they're adopted. However, you do have an increased risk if you're adopted and the adopted parent has schizophrenia. Neurotransmitters. Dopamine hypothesis. An overabundance of dopamine or too many dopamine receptors are responsible for the onset and maintenance of schizophrenia. Drugs that increase dopamine levels can produce schizophrenia-like symptoms. Medications that block dopamine activity reduce the symptoms. So high levels of dopamine in the limbic system can lead to hallucinations and delusions. Low levels of dopamine in the prefrontal cortex can lead to negative symptoms. Brain anatomy. So one thing is they believe enlarged ventricles could be a contributing factor. reduced gray matter in the frontal lobes, and many show less frontal lobe activity when performing cognitive tasks. Events during pregnancy have also been linked to perhaps a greater prevalence for schizophrenia. These include obstetric complications during birth, mother's exposure to influenza during the first trimester, and mother's emotional stress. Dissociative disorders. Dissociative disorders are characterized by an individual becoming split off or dissociated from their core sense of self. Memory and identity become disturbed. So, dissociative amnesia is an inability to recall important personal information. Usually follows a stressful or traumatic experience. Dissociative fugue is when an individual suddenly wanders away from home, experiences confusion about their identity, and in some cases may adopt a new identity. Depersonalization or derealization disorder is characterized by recurring episodes of depersonalization or derealization or both. So, depersonalization are feelings of unreality or detachment from or familiarity with one's whole self or from aspects of the self. Derealization is a sense of unreality or detachment from or unfamiliarity with the world, whether it's individuals, inanimate objects, or all surroundings. So, depersonalization may be where, and this is common to an extent, um, but with this disorder is obviously way more pronounced. This feeling of being outside your body looking in. Um, is the best way to kind of describe it. And it could cause a great deal of anxiety. Um, Derealization isn't where you kind of feel like you don't belong in your body or that, you're outside of your body looking into yourself. It's this feeling of being detached from the world around you. Um, Dissociative identity disorders is formerly known as multiple personality disorder. In this disorder, an individual would exhibit two or more separate personalities or identities. It involves memory gaps for the time during which another identity is in charge. Individuals tend to report a history of childhood trauma. The adoption of multiple personalities may serve as a psychologically important coping mechanism for threat and danger. Dissociative identity disorder is extremely controversial and it is not necessarily a well-established disorder in psychology. It is in the DSM. It is something you can be diagnosed with. However, there's a lot of psychologists that are very skeptical about it. Personality disorders. Personality disorders are characterized by a pervasive and inflexible personality style that differs um, markedly from the expectations of the individual's culture and causes distress or impairment. It generally begins or starts becoming pronounced in adolescence or early adulthood. Um, Slightly over 9% of the U.S. population suffers from a personality disorder. Avoidant and schizoid personality disorders are the most common. Antisocial and borderline personality disorders are the most problematic. Um, Whereas most psychological disorders now, there are pretty well established treatments for um, that somewhat work. Some disorders are far more treatable than are others. PTSD has very good success rates with treatment. Um, Depression can have some good results. Anxiety disorders, schizophrenia, because they're so genetically linked, is kind of limited in how people can live with it, but you certainly can have a rich, full life. Personality disorders are a little bit different in that they're very difficult to treat because you're talking about innate um, parts of a person's personality. And those are very difficult things to change. There are treatments for them. However, it takes a very long time and a lot of willpower and a lot of dedication on the part of the patient to deal with them. So there's three clusters, three main sections basically of the personality disorders. So cluster A includes paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. Cluster B is the antisocial, histrionic, narcissistic, and borderline personality disorders. And cluster C are the avoidant, dependent, and obsessive compulsive personality disorders. So, borderline personality disorder, um, kind of getting the first one here, is characterized by instability in interpersonal relationships, self image, and mood, as well as marked impulsivity. Symptoms include that they cannot tolerate the thought of being alone. They'll make the person frantic, efforts to avoid abandonment or separation. Relationships are intense and unstable. Um, Unstable view of the self might suddenly display a shift in personal attitudes, interests, career plans, and choice of friends. May be highly impulsive and may engage in reckless and self destructive behaviors. May sometimes show intense and inappropriate anger. Can be moody, sarcastic, bitter, and verbally abusive. The prevalence is about 1.4% of the U.S. population, and it's comorbid with anxiety, mood, and substance use disorders. Um, Causes are core personality traits such as impulsivity and emotional instability, show a high degree of heritability. Many individuals report childhood abuse. Um, if you think of the single white female movie where the person gets the roommate and then the roommate starts copying her mannerisms, becomes really clingy, things like that. If you guys remember that movie, or Fatal Attraction is another movie. I know both of those are a little bit older movies, but they're really good examples of somebody who has borderline personality disorder. Um, and indeed, being in a relationship with somebody like this can be kind of fun, right? Because and at the start, they are really into you. They just love everything about you. They think you are the most amazing person in the world and are really into this relationship. But when you start kind of asserting a little bit of independence and a little bit of, who you are as an individual, they get triggered by this because they think that you're rejecting them. And you do not want to be seen as rejecting somebody with a borderline personality disorder, because that's when they start getting these angry outbursts, sarcastic, bitter. They can be hostile. They can be violent. Really negative things start coming out. Antisocial personality disorder. Please don't make a mistake on this. It used to be called. They used to be called sociopaths. Um, People think of antisocial personality disorder as being serial killers. While it's true that most serial killers, and indeed one could even say most people that have committed crimes, or that are not not committed crimes in the sense of just did one crime, but like are perennially in prison nonstop, constantly going in and out of the legal system, have antisocial personality disorder. It does not mean that everybody with antisocial personality disorder um, have criminal mindsets or are serial killers, although that is one of the symptoms. So it's characterized by a complete lack of regard for other people's rights or feelings. Symptoms include repeatedly performing illegal acts, lying to or conning others, impulsivity and recklessness, irritability and aggressiveness, failure to act in responsible ways, a lack of remorse, overinflated sense of self, um, superficial charm, and a lack ability to empathize. So, diagnosis requires individuals to be at least 18 years of age. Um, Prevalence, it's observed in about 3.6% of the population, and it is by far more common in males than it is with females. I think the rate is something like 70 or 80% male. Interesting side note, it's not diagnosed in individuals under 18. Most most disorders have a separate class, at least in the DSM, for children under 18. Some of them kind of have a direct correlation to adult disorders. However, they don't generally label children as having adult disorders because they're not developed yet biologically or psychologically. However, there is a disorder in childhood called oppositional defiant disorder, or ODD, that shows a lot of correlation to antisocial personality disorder. So, what they found is that a lot of children that have ODD, pretty much once they hit 18, they have antisocial personality disorder, only because we don't label children with this disorder and we don't label adults with ODD. So some of the causes, genetics, personality and temperament dimensions related to this disorder, such as fearlessness, impulsivity, antisociality, and callousness, have genetic influences. The adoption studies suggest that antisocial behavior is determined by the interaction of genetic factors and adverse environmental circumstances. Emotional deficits. Individuals with antisocial personality disorder fail to show fear in response to environmental cues that signal punishment, pain, or noxious stimulation. So they show less skin conductance, which may indicate emotional deficits. So, quite simply put, they just are incapable of feeling those 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 feelings. Brain anatomy research has revealed that there's less activation in brain regions involved in the experience of empathy and feeling concerned for others. Greater activation in a brain area involved in self awareness, cognitive function, and interpersonal experiences. And indeed, one thing with antisocial personality disorder that is true is, generally speaking, um, people with that disorder are actually above average in intelligence. Not emotional intelligence, but in their actual intelligence, they're actually considered to be above average. So, disorders in childhood. ADHD, which is attention deficit hyperactivity disorder, is a neurodevelopmental disorder. Um, Neurodevelopmental disorders involve developmental problems in personal, social, academic, and intellectual functioning. ADHD involves a constant pattern of inattention and or hyperactivity and impulsive behavior that interferes with normal functioning. So, symptoms are broken up in inattention and hyperactivity branches. So, inattention is difficulty sustaining attention, failure to follow instructions, disorganization, lack of attention to detail, easily distracted and forgetful. The hyperactivity symptoms involve excessive movement, interrupting and intruding on others, blurting out responses before questions have been completed, and difficulty waiting one's turn. Prevalence is about 5% of children. Boys are 3 times more likely to have ADHD than are girls. Some life problems: low educational attainment, low socioeconomic status, unemployment, lower wages, substance abuse problems, and relationship problems have all been linked to ADHD. So, causes: the inattention part is about 71% heritable, and the hyperactivity part is about 73% heritable. So, clearly, very strongly genetically linked. Um, as far as neurotransmitters go, dopamine is one of the thought processes is that dopamine uh, genes involved are thought to include at least two that are important in the regulation of dopamine. Individuals with ADHD show less dopamine activity in key brain regions, especially those associated with motivation and reward. Medications have stimulant qualities and elevate dopamine activity. And it's a little bit um, odd to most people that we treat ADHD with stimulants. Uh, but when you kind of think of the brain chemistry behind it, that the inattention and hyperactivity are actually linked as a kind of um, response to having this lower dopamine activity, then it kind of makes a little bit more sense that giving stimulants actually helps with it. So, brain anatomy. Studies show smaller frontal lobe volume and less activation when performing mental tasks with people with ADHD. Frontal lobe inhibits behavior. It may explain hyperactivity, uncontrolled behavior of ADHD. Autism spectrum disorder, ASD. Um, and this is something that has become very, very prevalent, but it's also come to the forefront, and there's a vast amount of research being done in autism now. In fact, I believe after cancer research, autism is one of the best funded diseases slash disorders for research. So symptoms, deficits in social interaction, such as they do not make eye contact, they turn their head away when spoken to, and prefer playing alone. Deficits in communication, examples on that would be one word responses, difficulty maintaining conversations, echoed speech, so they just mimic what you're saying, and problems using and understanding nonverbal cues. Repetitive patterns of behavior or interests. So a lot of times with these types of children, they may end up having extreme organizational things where they would have toys that are lined up from tallest to shortest, or most expensive to least expensive, or some kind of structured pattern like that. Prevalence. It affects approximately 1 in 88 children in the United States and is 5 times more common in boys than it is in girls. Some of the causes, genetics. Identical twins are 60 to 90%. Concordance rate, fraternal twins are about 5 to 10% concordance rate. Genes involved are those important in the formation of synaptic circuits that facilitate communication between different areas of the brain. Environmental factors, factors that contribute to new mutations, such as pollutants. Um, that's pretty much the end of the psychological disorders chapter. Again, it is a really big chapter. It covers a vast amount of material. I honestly did not give justice to each individual disorder. If there's something or a specific disorder that maybe you want to get more information on, by all means, research it yourself or look into the textbook. Textbook explains it a little bit better. Also, feel free to reach out to me. This is a topic that I actually find very, very interesting. I have a lot of passion for it. So if there's stuff that maybe you want to find out a little bit more about, feel free to reach out to me. The one thing I will caution everybody about during this chapter, especially, is don't fall for the WebMD effect. So don't think, oh, wow, I get kind of depressed sometime. I must have major depression. Or, sometimes I get depressed, but then I feel really energetic. I must have bipolar disorder. Um, the thing that differentiates psychological disorders from like biological disorders is that it involves things that all of us feel and experience. It just does it in a much more profound way. So nobody has just a little bit of diabetes from time to time or a little bit of cancer. I've never after a big meal caught a little HIV or something, and then passed it. But with psychological disorders, everybody experiences depression at some point in their life. Everybody feels depressed at some point. People sometimes can wake up in the morning and just be really, cranking to go, and you want to have a great day and you have all the energy in the world. Um, Indeed, even something as far out there as schizophrenia, sometimes people have some pretty delusional thoughts or feelings about themselves, right? It does not mean you have those disorders. It means that you're a perfectly normal, healthy person. People with those disorders just experience something that we all experience, but they experience it to a far greater degree and for far longer time periods. So just keep that in mind. Chances are you are 100% perfectly normal. You do not have a psychological disorder. Um, but as I said, if you do want to find out anything else in greater detail, please come back with me, get in touch with me. I'm all ears. I'm here to help you. Thank you very much.